Hello, good evening, everyone. Thank you for joining us for our first live session of the Race and Health discussion on the racial disparities in healthcare. I'm so glad you were able to join us tonight. My name is Shanyeri Eze. I'm a medical practitioner with Eze Family Health Center. I'm joined by a wonderful group of ladies in various areas of the healthcare and mental health industries. It's going to be a very in-depth and fascinating discussion, and I'm hoping we can get all of this content in tonight, really addressing a lot of the issues that are related to race and health. So without any further ado, I would like to go ahead and introduce our panel here. We have our panelist, Ms. Delana Watkins. She is a board-certified registered nurse and CEO of Transitional Care Consultants, a consulting firm providing patient advocacy and transitional management solutions. Her specialty is in healthcare advocacy and preventive health services. We want to welcome Ms. Delana Watkins. Thank you.
And thank you so much for having me.
Certainly, Delana. And our next panelist is Ms. Raquel Reed. She is a transformational therapist, life coach, and CEO of Empower Consulting. Her specialty is in mental health, emotional clarity, and support of the transformative process through understanding of self-perception. She is also founder and host of the Power Within webcast. Ms. Reed has been featured on a multitude of platforms and is a best-selling author. We want to welcome Raquel.
Hi, welcome. Thank you.
All right. Our next panelist, Dr. Ijeoma Moforo Imwan. She is a graduate of the renowned HBCU, Florida A&M University, where she received her degree in a Doctor of Pharmacy. She currently works as a clinical pharmacist specializing in pediatrics and women's health. In addition, she is currently the vice president of the Nigerian Pharmacists Association of Tampa Bay and also sits on the board of directors for the Minority Women Pharmacists Association. We want to welcome Dr. Moforo Imwan.
Okay. Thank you.
All right. Next, we have Dr. Leslie Nwoke. Dr. Nwoke is a licensed psychiatrist, executive coach, renowned speaker, and founder of Heart Work Now. Dr. Nwoke has been involved in helping disenfranchised populations through her past work in the Ruby Project. In addition, she has helped entrepreneurs, CEOs, and corporate executives confront underlying emotional roadblocks to maximize their achievements for success. We want to welcome Dr. Nwoke. All right. And next.
Hello, everyone. So happy to be here.
Certainly. Thank you. We have our moderator for this evening, Dr. Giselle Martin. She is a doctor of public health and preventive medicine. She's also a wellness coach and founder of Heal the Public, a collective to help address issues that affect minority communities. She has expertise in health policy and currently serves as a professor at Georgetown University. In addition, Dr. Martin is a certified health education specialist and has committed years to serving underserved minority communities to assist in improving health outcomes and disparities concerning healthcare access. We want to welcome Dr. Giselle Martin.
Thank you for having me.
All right. So we're going to just go ahead and start with our topic tonight. We have quite a number of things that we want to discuss in regards to race and health and how racial disparities in healthcare currently exist. Really talking about a few key factors here when it comes to healthcare and the racial disparities. One is access. The other is implicit bias in healthcare, health outcomes, the disparity in statistics in concerning chronic disease, mental health, and then we'll touch upon a little bit of the statistics that are in relation to COVID-19 that is disproportionately affecting the African American communities. So just starting with a few basic statistics in all elements, what we're dealing with when it comes to healthcare disparities. We're seeing higher percentages of African Americans that, are dying at earlier ages. that are experiencing chronic disease at a higher rate in comparison to whites and Caucasians. We're seeing higher suicide rates. In 2017, higher suicide rates among African Americans ages 15 and 24. And then, of course, in the most recent COVID-19 crisis pandemic that we are experiencing, up to at one point, there was 60 to 70% of mortalities related to COVID-19 were among African Americans. So, I mean, this is something that these are very staggering statistics. And, you know, it's one of those things where we really have to get to the root of, you know, how did this happen? What led to us, you know, experiencing these disparities in healthcare. So I know we have Dr. Giselle. It looks like we may have lost her in a moment, but I did want to go ahead and proceed with the topic of discussion. You know, we talk a lot about how mental health can be a one of the areas of disparity among African Americans. And I know Raquel and Dr. Nwokwe, those are your areas of expertise. In your experience, in your areas, what have you found has been kind of the hallmark of issues among African Americans when it comes to mental health? We can start with you, Dr. Nwokwe.
Yeah, absolutely. No, thank you so much for that question, Chinyere. You know, when it comes to people of color and mental health, there has been just a huge kind of like burden that we need to kind of overcome. Specifically when it comes to looking at biases in these particular groups. Oftentimes you may have unfair biases put on people of color. So let's say, for example, you have someone who comes into the ER and they are a person of color. It may be assumed that they are not having a psychotic issue that really needs treatment. They may be assumed to be drunk or to be acting out of hand. And so when we have implicit biases that come up like that, that has a very explicit and direct effect on healthcare. Oftentimes we may have people who you know, children of color who are struggling with attention deficit disorder. But instead of it being seen as that, they're seen as just, you know, like they are labeled as being conflict oriented or someone who is not paying attention, when they quite literally have a problem with executive function from their frontal lobe and they need support with that. So we have implicit biases that show up in that way. And then, you know, I know some providers may not want to admit, but they may even have explicit biases, such that, you know, people who are obese may not be adherent to medication, or people who have a past history of addiction may still be doing that, right? And so these are some of the unchecked thoughts that as providers, and honestly as people as general, that we need to just be able to call out for what it is. And so that's what we're seeing in mental health, and it is prevalent throughout much of healthcare.
Right. Yeah. Go ahead, Raquel.
Yeah, and I'd like to add, I mean, that brings up the notion that there needs to be more culturally competent providers in all areas. So, for example, you know, in the therapeutic world, I remember a Caucasian practitioner, and this was not just one, this happened a lot, where a Black woman would come in for support, and they would do their head like this. And they would get diagnosed with having a tick when all that was wrong was that our wig was a little itchy. So we gotta educate them, because it's, you know, and it's okay to go see someone who's not of the same race. However, these kind of problems do come up. So we just have to know that. I think the other thing is the idea that when we talk about mental health being labeled, we're going to be labeled. Oh my goodness, I don't want you to label me. Absolutely. Right? So then there's the stigma with getting the help that we need because we're going to be labeled. Good example is I was working a few weeks ago with a contracting with a different company, and in their system, in their EHR system, if I didn't put a certain type of code on that visit, I couldn't even get to the next screen. So there's something in the system that says we must label people. So we become professional labelers, and it deters our people from getting the help that they need.
Right. Yeah. So it seems like a lot of it is, and like Dr. Nwoke was mentioning about that implicit bias, where medical providers may not even be aware that they are putting these kind of subconscious labels on their patients, and that changes how they interact with them, how they perceive them. There's even statistics that I've read that African Americans are viewed in a more negative or perceived as being even combative within the healthcare realm, and that can affect a lot of ways that they're, how they're treated, what medications are given to them, how they're managed overall, and that could have, some real impact. So, looking at even the historical context of like what is getting to the root of, why are there these disparities that exist between, and we're of course talking specifically about, African Americans in comparison to white Americans. So really looking at that historical context, like where did this all come from? I know Dr. Giselle, you definitely have some insight in regards to historically, how did we get here in regards to these racial disparities that we now have?
Yes. I apologize, guys, but my computer actually restarted on me. But some people might actually wonder why we are even talking about the historical context just to get started. But we can't understand what we need to fix without understanding the relevance of what's already happened in the past. And that's pretty much with anything, especially as you start talking about policy. So I think when it comes to the historical context, most people, they think about the Tuskegee syphilis study, which is, it's one of the most notorious abuses of Black people by physicians in the United States to date. And it wasn't a singular episode of ethical misconduct. This happened actually all the way up into the 1970s. A lot of people don't realize just how long this particular horrible experiment went. And so for those who are not really familiar with Tuskegee and what happened there, was basically Tuskegee is a small town in Macon County, Georgia. And so there at the beginning of the 20th century, it was predominantly Black. It was made mostly of sharecroppers that were made of freed Blacks. And the United States Public Health Service used this as an opportunity to create a study that tracks how syphilis affects and kills the human body over time, over decades. However, what was happening was that people were, some people had syphilis and they were not given penicillin, even though the United States Public Health Service knew that it would treat syphilis. And so just to put it in plain, simple terms and not take up too much time, these people lived with syphilis untreated on purpose for a very, very long period of time. And you think about it, there's still a large number of people who had relatives who this impacted, and they're alive right now. So you have these perceptions that are played throughout the Black community. And this is just one particular thing. The actual rise of scientific racism leads all the way back to slavery. And it started with a set of beliefs that seeks to manipulate scientific practices in order to prove that Blacks were inherently inferior as a people. And you have scientists such as Samuel Cartwright, who went out of his way to really prove that Blacks were hypersexual, that they were liars, they were dangerous, they were indolent, they were lazy, all of these perceptions that some kind of way still seem to be carried on and observed in various ways throughout our society, even now, hundreds of years later. You have the antebellum medical experimentation with slaves and freedmen, where this was where white doctors would subject slaves to various terrible experiments. And I mean, they would have, like, for instance, they might treat heat stroke, which was very, very common among slaves, as you can imagine, being in the hot southern sun all day, sometimes without any water for hours at a time. And so to cure heat stroke, they would have African slaves actually sit and stand on coals for hours just to see if they had a different response to pain. And I mean, it was all kinds of crazy things that happened back then. But these particular experiments morphed into modern day, even gynecology, female reproductive practices even now. So the study of eugenics and how that was first developed was that scientists would argue that certain women were not fit to carry children. And eugenics ideally has two branches. So you have positive eugenics and negative eugenics. Positive eugenics is where you encourage reproduction, so that way you can pass beneficial traits down through your children. And then you have negative eugenics, which is where you forbid people to have children, basically, because you don't want them to pass on their negative genes. And so this concept was used in the development of the birth control pill. And in the 1960s, it was primarily encouraged for Black women to take this pill, especially if they had any type of social stigma, if they were incarcerated, if they were poor. The thought was that you're not good enough, and so your children are not going to be good enough. And it led to different projects like the Negro Project, where there were clinics that opened primarily in Black neighborhoods, and it encouraged the adoption of birth control to help with Black population control. And so, I mean, there's so much to this story that helps frame the current state of where we are in healthcare as it pertains to minorities, especially Black Americans. So, I mean, there's so much more I could talk about. Epigenetics. Epigenetics is basically the study that our genes are modified by our experiences and not necessarily just the nucleotide sequences in our DNA. So it's more than just the T's and the A's and the G's and the C's. It's, were you incarcerated? Was your grandfather, was he impoverished? Like, all of these things, these elements of our environment and our experiences are thought to influence who we are. So when you start incorporating all of that, plus the other historical traumas, it's very easy to see why so many Black people carry the disparity in so many different areas of healthcare. So, I mean, that's in a nutshell. I could literally talk about this all day, but there's a lot to unpack.
Yeah, Giselle, and you said so many things there. Often we want to relegate history as it's in the past. It doesn't affect what's going on now. You mentioning about, the experiments that they did on African slaves and how they were able to tolerate heat or tolerate pain. Well, that is even translated and impacted, our modern ways of providing healthcare. So they did a study, and it was actually within the past 10 years, where they did a study on medical students, and they discovered that often a lot of these medical students did carry perceptions of Black people were able to tolerate pain better and more. Black people had thicker skin, which is, false. And then, there's these perceptions and thoughts that, okay, African people, African Americans are somehow different. So therefore their applied healthcare would be different. So pain medications aren't prescribed as often because it's perceived that Black people can tolerate pain better. So these are things that are still carrying over even within the past 10 years of medical students. These are our future healthcare professionals. So it definitely does have an impact, and it's important that we understand that historical context. I know before we even went into that, I don't know if anyone else had anything else to mention in regards to the historical context of why we have these disparities. But Giselle, before we started on that, we went into implicit bias. That kind of is certainly a relation there. How healthcare providers perceive their patients based on their race. We find that there's a disparity even in the number of physicians that are African Americans. I think in the 2017 study, it's roughly about 5% of our current medical doctors are African American compared to roughly 52% that are white. So, in relation to what Raquel said earlier about, that cultural difference and how we interpret certain behaviors and things and how that can impact, healthcare outcomes, it's very relevant and important.
Absolutely.
Yeah. So I know, another area that we find is problematic is even going back to how African Americans are perceived as tolerating pain better or more. Ijama, I know Dr. Maforo, in regards to mortality, I know you work as a pharmacist in women's health. We're seeing higher mortality rates among African American women. So yeah, I want to hear your commentary on that.
Definitely. I think for a while it was probably something that was not really looked at per se, because I think what brought it to light just recently, I don't know if you all remember when Serena Williams had her daughter Olympia, and I think it was right after she gave birth that she mentioned to her physician, like, hey, something's not right, I can't breathe. And then they discovered that she had blood clots, a pulmonary embolism, where she had to have emergency surgery. And then it was like, wow, okay, she almost died after giving birth. So at that time, people were like, okay, wait. I mean, prior to that, there was a lot of other, stories that we would hear here and there, and it really wasn't, talked about. It had to happen to a famous person. I think sometimes with a lot of things, it has to happen to someone we idolize, so to speak, and then we kind of look at it a little bit more. But the difference is, especially in a first world country, we're almost one of the top. I mean, this is the United States of America that everybody looks at as, the place to be. And African Americans are dying. African American women are dying at a rate of 3 to 4 times higher than white American women after, giving birth. The CDC looks at the mortality rate up to 1 year after. Some other organizations look at it up to 42 days after the giving birth, and they would consider that part of the statistics that have to do with mortality rates for African American women. So, and when they look back on some of the things on why, and what I can honestly say is I love the fact that the CDC is doing a lot. They've donated, I think they've put over $45 million into helping facilities, make committees that can help look at why is this happening? After a woman gives birth, why is she dying? Or or I should say African American women, why is she dying? What happened? Where did we go wrong? So I think those are the things that we're starting to see, and it's really being pushed. I mean, just recently, I think a very young lady, she was a story that I saw where after giving birth, and it was her second child, she was leaving the hospital, or she was in bed, and the husband noticed, blood in her catheter. And he was like, why is there blood? And told the nurse, informed the physician, and she wasn't looked at until about 10 hours later. So why was that not looked at as emergent? Could it have been, like you said, subconscious racism? Oh, she's okay. Oh, that's normal. Why wasn't it looked at? Subsequently, this young lady passed away. So I think that's one of the things that we need to look at and be involved in. Just like you said, Chinyere, about only 5% of physicians are African American. So that's another thing that we could also push is, hey, she looks like me. Hey, he looks like me. Maybe he might be able to, there's that the relation thing. It's almost being a pharmacist, I see it a lot too, is being able to talk to, other African Americans and being able to understand them. I give you a perfect example. There was one time, this was when I was a student, and I went to a hospital. I was on my last year of pharmacy school, and I attended, I was on rounds, with other physicians. And it was about a group of maybe 10 of us. It included residents, the attending, and other students. And here I am, the only African American student, or the only African American amongst the group. And it was an African American male in the bed, and the doctor asked him a question. And the guy answered. I understood him perfectly. I looked and I was like, okay. The doctor said it again. And he was like, I can't understand what you're saying. Can you say that again? And the guy said it again, and I understood him perfectly. So I now repeated what the guy said. He, what we would say, he was speaking Ebonics, he was speaking slang and things like that. But I understood what he was saying. So, and I translated to the doctor. I say translated. I told the doctor what this person was saying. And he was like, oh, okay. And then the doctor was kind of happy that he knew what the guy was saying. He now asked the guy another question. The guy answered, and the guy said, the doctor, it was the funniest thing. Everybody in the group turns and looks at me like, what did he say? And I'm sitting here like, he's speaking English. But look at just that little scenario alone. The doctor totally didn't understand what he was saying. Now, what if I wasn't there to quote unquote translate his slang to the doctor? And that was the only way he could communicate. So it's situations like that that, we see and we're like, wow, lack of communication. Could the same thing be happening also in African-American women when they're trying to translate their pain to the doctors with women dying? We're seeing, of course, we do have our comorbidities, as mentioned by Dr. Giselle. We have our comorbidities, higher rates of hypertension, higher rates of obesity amongst our community, which definitely play a role. But then we have that pain tolerance scenario that also plays into it also. If a woman is sitting there like, oh my God, I am literally in so much pain right now, and you guys aren't doing anything about it. Sometimes it's looked at as, oh, this is birthing pain, you're okay, and they see us to be, combative or over dramatic, little things like that. And that's usually not the case. They really are in pain. So sometimes these things are missed, and the statistics show it. The statistics cannot lie. 3 to 4 times, that is huge, especially for a country like the United States of America, a first world country. And for us to be close to the top, that's kind of disheartening. So those types of things, and the same thing goes along with COVID-19. We're looking at African Americans being 5 times more likely to die from COVID-19 than we're seeing any other ethnicities or any races. And so that's what makes it even more difficult, because you wonder why. Like, why is it just African Americans? A lot of people, like I said, the same thing. Comorbidities play into it, yes. But do we know if there's any racial biases that play into it? We don't know, because sometimes physicians kind of don't connect with us. And that's just being real. Being that myself, Like even when I was a pharmacy resident, at the facility that I attended my residency, I was the first African-American resident. So I almost felt like I had to prove myself in many ways, and I was treated differently. I was treated differently just based on my race. I mean, it included ageism, racism, everything, but can you say that that played a part in my development as a pharmacist? Yes, it did. And it pushed me to be part of organizations. Minority Women Pharmacy Association is one of them. This group was founded because of the health disparities. We have to help ourselves. We have to help ourselves. And so that's why I also took a liking and took an interest in women's health. When I see these disparities in African-American women, it baffles me, especially being in America. It really baffles me. And seeing that we continue to have these issues is something that we definitely need to look at. I love the fact there's many organizations. I don't want to mention too many of them. You can easily see plenty of them that are out there that are advocating for these women and for African-American women in healthcare and African-American women who are giving birth. Why is this happening to us? Why? I mean, the statistics have been looked back at from the early 2000s because they noticed, whoa, hold on, wait. Why are more African-American women dying from just what we would call simple childbirth? And even though the rates had actually improved, when they looked at the statistics in 2017, well, guess what? It was still bad for African-American women, even when there was an improvement. So I think these things are so important to look at, and for people to be involved, for people to be advocates for African-Americans, not just African-Americans, but other races and other ethnicities too need to see some of these disparities and help with why is this happening. Right now, I would love if I could post this to, share this on a group of doctors that were majority, gynecologists per se, speaking of this topic, so that they can see that we do have a concern. Why is this happening? Understand us. I know some facilities now are actually are trying to learn about African Americans. They're trying to learn the culture. They're trying to understand. I mean, some of the things, they might sound very trivial to us and almost laughable, but they're important. When somebody uses the slang like, I ain't feeling good right now. To us, that's
some kind of way.
But it's letting them know how we are feeling. It's letting them know and translating, this is how they speak. And I think that's what a lot of that happens. I've seen it myself, going to counsel patients, and some of them are like, oh, thank God it's you, and I'm just like, why? And they're like, the doctors just don't understand what I'm trying to tell them. And also speaking to them in a manner that they understand. If a person comes into a pharmacy, some people don't, yes, they use different words, but okay, I'm not going to tell them, okay, this is your anticoagulation medication. I'm going to say this is your blood thinner. So it's ways that we speak to them. And I'm not saying that the same doesn't happen with non-African Americans, because some of them, depending on the socioeconomic degree, we're going to speak the same way. But that's what we tend to see a lot. Your sugar diabetes, or your sugar's high, your medication for your sugar, you're not going to say diabetes. So these little things play a huge role in why there's this huge disparity in African Americans versus other races. So it's something that we definitely should look at and look more into. But definitely the statistics are mind-boggling, and definitely need to be looked at. And I do, like I said before, I do applaud CDC and the World Health Organization to the fact that they have concern for this, the fact that they are, trying, and several organizations are definitely looking at this also. So we're headed in the right direction. It's good for us to be having this conversation about it, because there needs to be more understanding, as you've seen in the mental health issues that we have, the history of it, I think the history of what we're seeing today is extremely important. A lot of people say get over the past, just like Dr. Giselle mentioned, but you can't. That's how you understand. That's how you're able to understand why what's happening is actually happening.
Right.
Thank you so much, Ijoma. That was
Dr. Mufaro,
yes,
you hit so
agree.
much. If I could comment.
Yes, I see there's a comment for Ijoma. We are going to take comments at the end, or questions at the end, if you guys don't mind, because I want to make sure we have enough time to get through. We will get through everyone, but we want to make sure that Delanya has time to speak and share some knowledge with us. But Ijoma, I do remember actually the gentleman that you spoke of who lost his wife to, I forgot what the exact reasoning was, but she bled out basically. He actually shared, he came to Mayor Muriel Bowser's Child and Maternal Health Summit this past year and shared with us, and it was a very tear-filled experience, but just hearing him talk about the span of time, like it was a long period of time that they had to catch this for this young lady, and it was just neglect. A lot of this stuff boils down to neglect. I mean, even when we start talking about some of the higher rates of chronic disease that's been observable in Black Americans for so long, this is not new stuff. So these are things that we could have addressed years, decades even ago, but we chose not to, and because the policies don't necessarily lend to that. I will say, in the case of your example with maternal health and really only following women up to a year after they deliver, there are a lot of policy initiatives that are going on even within like EPSDT, which is primarily for children, but they've partnered a lot with the maternal health services where they're following women up to 2, 3, 4 years after childbirth now. So they are realizing that there is a certain level of engagement with women even after childbirth. So we're doing some work, but we have to get there. And so our biggest thing is, I mean, everything that you shared kind of falls within not even just the chronic diseases, but it's just the health disparities. But with that, we have like diabetes, cancers, all kinds of different things that are just taking over Black and Brown communities. And there has to be a way, there are ways. It's just a matter of us implementing ways to get this under control. So Delanya, do you want to share a little bit more about with us, like about these high rates of preterm birth and chronic diseases and infectious diseases that we're seeing in Black and Brown communities?
Absolutely, sure. So I hope you guys can hear me. I know that I'm freezing on my end, so hopefully you can hear my voice, even if my photo is kind of choppy on my end as far as freezing. But the power of my voice and what I want to share, hopefully you all will be able to hear that. And as it relates to the topic of chronic conditions and looking at, again, us, it's so funny. And I think, I can't remember which one of the wonderful panelists talked about this, how we make up such a small number in some cases of whether it's diabetes, hypertension, but yet we have a higher mortality. So the number of us that may be necessarily in that pool of consideration, especially for cancer, but yet we have a higher mortality rate. So I think it's somewhere around 77 to 80% of African Americans that may be diagnosed with a particular condition, let's say diabetes, for instance, but yet we have a higher mortality rate because it's not being managed properly. And so I want to just pivot a little bit and just talk about the whole advocacy piece, just because right now I think we're doing such a great job of empowering ourselves and talk about patient advocacy the same way we are about social injustice. I want us to be given the power to know that we can advocate for ourselves. But then that goes back to understanding what it is that we're able to advocate for. What should good quality healthcare look like? And I think that's where all of us come in with our various backgrounds and our focuses and what we're doing. And that is making sure that we are able to spread the message far, deep, and wide, and let African Americans and people of color know that they do have the right to advocate for better quality health. And what does that look like for them? Before, Shaniera, you shared how only 5% of the physicians look like us, right? And so that leaves us with this whole other sector of individuals that don't look like us, and so therefore may not understand our walk and or our challenges as it relates to socioeconomic lack of resources, maybe even understanding how and what's being told to us when we are diagnosed with diabetes or hypertension, that we're at greater risk for stroke if those things aren't managed. So I think a lot of it just goes back to advocacy and awareness and being able to educate us. The other thing is we have to then tie that into making the healthcare providers understand too that for them it hits them in the pocket. Health disparities cost the United States several billions of dollars without them putting the dollars where they belong. And so health advocacy is one of those lanes, one of those buckets that I feel like that money should be put into for sure. And that is to help the average individual to understand simply, if I'm being diagnosed with something, give me the tools and resources that I need to manage that condition. It's just that simple. Don't allow me to go through, have that condition become chronic, and then have it mismanaged, and then suddenly my life is, ruined, and I'm at a greater risk for even more comorbids. So I think just trying to tie it all together, just looking at a mouthful, it really behooves all of us to put money into advocacy, to put money into, cultural competency where it should be. And that's going to be obviously with the physicians. And then lastly, looking at how we're actually managing those chronic conditions, tying back to the money. Let me just kind of package this all in from everything that's being said. We know health disparities exist. Oftentimes things aren't done until, I think Ijama talked about this, and that is until someone of stature, something maybe happens to them. Also, the other thing that will get people to move is if they see that money is being affected or their bottom line is being affected. 2 projects that I worked on within the last 5 years, the only reason why money was funneled into certain specific communities was because it was costing the state, the county, and a major hospital system money to not do what was right by particular communities. And that surfaced around readmissions. And that was because one number on a zip code from a more wealthier part of this particular zip code to another meant that this without lacked the resources and didn't have what they needed. And then the one that had a zip code that ended in a 2 did have what they needed. And so the hospital was being seen as the readmission dwelling, if you will. So those that didn't have it was 1 doctor per 8,000 residents in this particular zip code. So the ER became their physician, and the hospital did not like that. It was costing them money. And so as a result, they then decided, oh, there must be something that we need to do. So let's create these health empowerment zones. Let's see what we can do so that these folks don't keep coming to the hospital for the ED to take care of them. And so that then spearheaded these whole health empowerment zones where they begin to look at zip codes to see how they could envelope and send resources their way. And so sometimes it takes for things to happen in the economic sense before these types of what we call health, disparities or health inequities, because the resources are there. It's just, do they have access to it? So when we look at health disparities and health inequities, they're really 2 different things. However, one could help to solve the other. And it's just a matter of us kind of enveloping that up and tying it up and putting it in a nice, pretty, package and saying, this is what is necessary so that, certain individuals, that being people of color, don't have to suffer through these health disparities.
Very good. I love what you said about your examples and the differences between I think what you're trying to get at is the social status versus, healthcare status versus healthcare disparities.
Right,
So
yeah.
Healthcare disparities, which look at ways that different populations interact within the healthcare system. So like, for instance, like, do vulnerable populations have equal access to services? Or are there disparities in the quality of the services that they receive? So this can be applied to utilization rates and all kinds of other things, whereas health status disparities consider outcomes measures. So, for example, how do mortality and morbidity rates differ between different populations? And so when it comes to that, I mean, there's so many different things that are going on out there when it comes to disparities. Even with bias, there's so much that providers can do to address their bias. However, there's still a clear relationship between, first of all, sorry, I like to explain, you guys know I'm a professor, so I try to put things in normal language. Like, my students ask me all the time, like, what's the difference between bias and racism? To be very clear, every single human being on this planet has biases in some form or fashion. I mean, we've been taught to believe different things. We've experienced different things that have shaped our perceptions of how we perceive other people. And that's okay. That's what makes us human. However, it becomes racism when you are blatantly active in the harm, like you're acting out those biases in a harmful way towards other people. So I wanted to kind of circle back to Raquel and ask, what is the relationship between perceived racism, specifically, not bias, and mental health outcomes in Black Americans? Because so much of what's been shared, yes, they impact the outcomes just in general from a healthcare perspective. I mean, and ultimately, politicians, they care about the numbers. I tell my students all the time, if you are really going to impact change, the people who give the money, they care about the numbers. They don't care about the qualitative side of things. They care about the numbers, the money, the outcomes, like where is it hitting their pocketbooks? So if you speak their language, that's where we start moving the needle. But we need to understand that with these outcomes come a mental and an emotional toll. Yes. So what toll is this racism that's being exhibited on this particular subset of the community? How is that impacting them from a mental perspective?
Yes, thank you. Yeah, that's a great question. And one of the participants actually spoke to that. Shamela Joyce said, are our diseases in part due to stress and overall environment? And so, I mean, everything that we've talked about really comes back to, we've talked about history, we've talked about advocacy, we've talked about just the definition of racism. And just recently, there was an article in the BBC in June about a young lady, her name is Kennedy Mitchum, who asked for the definition of racism in Merriam-Webster's dictionary to be changed to address the historical content of it, right? And if that's not advocacy, I don't know what is. It's advocacy for yourself, but it's also advocacy for the collective. So let me share with you the current definition of racism. It says that it is a belief that race is the primary determination of human traits and capacities, and that racial differences produce an inherent superiority of a particular race. And then there's a part 2 to that definition, which the editing manager of Merriam-Webster, his name is Sokolowski, said that he would actually make a clearer definition for this part 2, which is, here we go, a doctrine or political program based on the assumption of racism and designed to execute its principles. So he's positioning that he's even going to bring in Black subject matter experts in changing this definition, and they're looking for a change to happen in August. I'm sorry. Now, what's really important about this and stress is this young lady decided to become an advocate at this point because of what she saw with the George Floyd killing. And so it disturbed her like it has all of us on every level. But again, historically, we've been castrated and hung and all these types of for years, right? So it's now so blatant in our media. It's in the forefront of our minds every single day. Whenever my husband leaves, my dad leaves, you worry about that underlying. If you have a son, you worry about that. If you have a daughter, you worry about them and their well-being. And so there's a great impact of stress on our lives, and that is historical as well. Is where, and you are the medical doctors, and you can speak to that even more, but that is historical as well. So we have to continue to advocate because racism is a stressor. That's the end all be all. Racism is a stressor. So when you talk about perceived racism, okay, angry Black woman, I'm upset about something on my job, and now I'm labeled. Here we go, back to being labeled. I'm labeled. So I've perceived something. Now, prove it. Now, when you go to have to prove it, who you got to prove it to? A panel of Caucasians who will not. Listen, y'all wanted me here. I will tell the truth. That's who you got to sit and tell that story to, right? So then that's why we call it perceived racism, because now I have to prove that that's what I experienced. So at the end of the day, we are talking about what it is that we have experienced day in and day out. Many of us are in the positions that we're in. Like, I'm an entrepreneur now because I got tired of it. I wanted to be able to have my own options. And I tell my clients all the time, when you don't have options, or when you believe that you don't have options, that's a very dangerous place to be in. And our people have been in that place many times. So what needs to happen? We need to collectively, like this beautiful panel right here, get together, and we need this. For example, Viola Davis in that magazine, right? It's giving everybody life, isn't it? But the backdrop of that is, why is that the first Black person
right
have taken a picture that was on Vanity Fair? Come on now. Okay.
Exactly.
So the first that. And as Dr. Ijeoma said, she remembers being the only Black person in her. We all had that. You've been somewhere where you was the only Black person there. Oh, can I tell you guys a story? I have to tell you something. Okay, so here we go. I'm ordering Mary Kay Cosmetics. I go online, talk about a zip code, and I say, this is my zip code, and I'm going to purchase some Mary Kay. I purchased Mary Kay from a sister, right? Because I want to support my sister. Because that's another part of this issue, that if we're talking about dollars, we got dollars too, and we need to start putting those dollars in the right places. Now, makeup may not be the most important thing, but I needed it. Now, I ordered some makeup. So the lady comes to my house. She brings the makeup to my house. She says to me, "Oh, I didn't know you were Black."
Wow.
I didn't know it was important, but okay. So then she says, this book, the Mary Kay catalog, is not, in the best condition, but here you go. So what did she just say to me? This is a sister that says to another sister, because I thought you was white, I wasn't going to give you this book because it wasn't good enough. It wasn't in good condition. But because you're a sister, you understand. Here you go, with coffee stains, grease, and everything else on it. That's a problem. That's a problem. And we have to correct this thing from the beginning. And we are only going to do it collectively when we're honest and truthful about what is really happening. But racism is a stressor, and it finds itself in so many, like you said, Dr. Giselle, we all have bias. We all have that. And you know what? A lot of us are racist. So we have to deal with our own, y'all want to talk about it? Level of racism.
Racism, right.
So is it possible then for African American professionals or healthcare providers to have implicit biases against an African American client, patient, etc.? So that is existing.
Yes, it is.
I believe that.
Yeah, absolutely. Like it totally is, because like when you think about bias, I mean, all biases, first of all, as humans, we are all wired for story. Like we go into a space and we are actively, subconsciously though, but we are actively creating a story about the situation and the world around us. So even as providers or as entrepreneurs, like with our clients, like when we step into a session, into a room, we are already forming the story of what is already happening. And so biases really is, that's where we start to fill in the gaps of the story for people who we don't know, right? And so this is why it's important, again, like as we were highlighting, the need for more providers of color, because we know our story. And so as we're going into a room, like there are just few things that will get wrong, because it's like, well, we know each other, right? And so, you know, like one of the things that's so important is that if you are a provider, so speaking to our audience, if you are a provider, if you're someone that's seeing clients of the opposite race, it's so important to ask the question. You want to assess who makes you uncomfortable and why. And you want to get honest about this. And why this needs to be an intentional activity is because unconscious bias is what it is. It is unconscious, right? Dr. Martin, you were talking about, you know, kind of looking at historically, when we go back closer to the offending event, that is where we can say, okay, there is a thought of these people are bad and we will label them as other and we will treat them accordingly. But when you pass on that type of thinking to latter generations, they don't have the reason why. Like they just know, oh, I was trained to talk to so and so like this, or I was told to treat this other person this way. They may not know why, but it just becomes inherent. So that's why it needs to be an intentional activity of asking, like, who makes me uncomfortable and why? It's also really important to kind of look at, is the reason that you may feel uncomfortable their fault or your issue? You know, I've had many times where I've gone into a room with a patient, like when I was in training, and I had fair reason to be worried. You know, they came in with a gun, or they showed me their knife, or listen, I've had an incident where I went into the ER to see a patient. It was like 2 or 3 in the morning, and he pulled out his little friend, you know? So I had a fair reason to be uncomfortable. But when you're entering into a room, the person doesn't look like you. You're automatically on guard. You start to get awkward and uncomfortable. You start to overtalk, right? You need to pay attention to that. Why? Why did you suddenly get tense in that moment? There's a book that is called The Body Keeps the Score, and primarily he's talking about how our bodies hold trauma, but our bodies in general, they give information, right? So pay attention. Like when you get goosebumps, you kind of get that tick in your shoulder. Why did that person make you feel this way? You need to get honest about that. And it's important to also look at if those feelings come from societal norms or childhood. I've had colleagues who have said, well, they had a bad situation where it was a person of color that did something to their family. And so they kind of hold that, right? Or even like the opposite. But either way, it's important to call it out and say it for what it is. And then, you know, oftentimes, like when we look at the data as well, patients have said that they get more frustrated with providers who scored higher with implicit bias. And these were often the ones who they spoke the most in the session room. They didn't give the patient any time to talk. There was also a study that said something interesting that said that they were frustrated with patients, that patients were frustrated with physicians who used language like, we and us, like specifically saying, now we're going to take our medication, right? Now we're going to do the right thing, right? Because what that speaks to is this power differential of, well, you know, it's not you. I don't see you as the individual. So let me kind of like, I guess like sugar it up and say like we will do this, right? Almost kind of like patronizing the individual, right? So these are all places. Yeah, so like these are all places where patients are we're frustrated with, and I think also to kind of hitting back to advocacy. I think it was Raquel that was saying this too, or Delana, I'm sorry. As a patient, now speaking to those of you who come in as patients or as clients in a space, I cannot stress enough having your healthcare information on lock, right? In the unfortunate situation where you enter into a space where someone who will be discriminatory against you, be able to know what medication you're on, know that you take it, keep a log, things of those nature. And yes, it is the extra emotional burden or the extra emotional labor of that we may have to do in healthcare, but just have your stuff on lock so that no one can ever second guess or ask, right? And be willing to just kind of go there. Yeah, it's so important. It's so important. Lastly, I will say this. I think there's also room for just kind of more cultural interpretation. I'm Nigerian American. My parents came from Nigeria in the early 80s. And I can't tell you how many times, you know, back even when I was in training, or even like with what I'm doing now, like, you know, you have, you know, Africans who come in as patients and they are clearly in pain, but wanting to be respectful or wanting to not say too much or complain too much. And the physician or the provider takes it as, oh, well, like they're okay, like they're fine, and they move on. I remember very vividly a case I had, I think this is back when I was still in med school. I was on a rotation. There's a Nigerian woman who came in and she was in pain. I could look at her, like she was just kind of, she barely shuffled into the room. And when she sat down, you know, it was a surgery rotation. The surgeon came in and, you know, kind of looked at her and was just kind of like, okay, well, I know you're having some GI pain, but, you know, like it'll, you know, go away. Just kind of give it some time. And she nodded her head. She said, okay, yes, doctor, so and so. When my attending left, and I stopped her for a second, I said, let me go back and ask her a question. And then I put on my accents. I said, Auntie, you're not fine. Auntie, what's wrong now? And she started to cry. She started to cry. And she just was saying just in how much pain she had been. So it was in that moment that I now went back and I called the attendant. I said, she's not well at all. The woman ended up going into surgery, emergency surgery, because she was having, I think it was partial bowel obstruction because of like previous adhesions, you know. So it's so important, again, like, you know, here in the West, here in the US, we will look at it from a racial lens because those are the different groups that we have. But it's also important, again, in terms of culture, to not assume that someone is fine because they're quiet, to not assume that someone is, you know, being rowdy because they're asking a lot of questions. It's so important to stay quiet, listen, ask questions when needed, and be uniform in your approach to everyone. So,
well, can I add one thing there? Two things. That uniform in your approach, that's that bedside manner, but I'm going to say I don't agree with you. I don't want you to be uniform. I want you to treat me. Yeah, because listen, something on the inside of me, when you change that dialect, it was just so beautiful. And I know I got roots there somewhere. So I think you were speaking to my ancestors or something. But I felt it. It was just so, it just touched me because I could just imagine being in that room with
I'll
her.
qualify it for you. I'll qualify it for you. And what I mean by being uniform is, you know, if you if you're going to ask the Black man who comes in, have you done drugs? I want you to ask the older white lady who also comes in as well, because she could also be doing benzos. She could be, having 3 or 4 different prescriptions from somewhere else, and she's popping that every night. So that's what I mean by being uniform. If you're going to go in and check the young white woman who just had her first baby, and you want to ask, are you okay? Are you comfortable? I need you to go back and ask the young Black woman who this is her 3rd baby. She looks okay. She has family in the room, but I want you to go back and also be uniform in your approach with how you're also caring for her. So that's what I mean by uniform. It doesn't mean that we have to strip ourselves of the unique ways that we connect with patients, but we need to make sure that if we're caring for people, let's make sure that we get all the information for everyone.
Yeah. And I honestly love to just call it love. Like, take love with you everywhere you go. And I think everything will be fine. Now, I want to just come back and say something about you have another young lady in your chat, in your live comments, that says, thank you so much for addressing this. This is such a stressor. First, as an HR director of an organization that operates in unconscious bias on a regular, I'm always the angry Black woman while trying to do my job. Now, see, I have a heart for that, because I'm not just a therapist, I'm also a coach. And I coach people that are Black women that are in these rooms where they're the only one there, and they are trying to keep their head above water. They're constantly thinking about shrinking. Like, how do I fit in this room? The only way I fit in this room is if I shrink. Well, I'm here to tell you that is not the way you are going to fit in that room. You were created to expand. And that's exactly what you will do. You will not shrink for anyone. And so what happens when perceived racism, you see, I'm getting excited, I'm hitting things. When perceived racism takes a hold of us and it causes stress, it's because it's a function of cognition. It's about the way that we think. So that's why everything I do is about mind management. You don't have a mental health problem. You have a mind management problem. And if you begin to manage your mind and make it priority and do the inner work that is required, this is how we transform. This is how we change our situation as an individual, but then collectively, because you're not an island to yourself. Somebody else needs you, and somebody needs you to show up and be exactly who you are. That's what is required. So when Dr. Nwoki said, took that dialect and spoke to that woman's heart, she knew that she was heard. How many times as Black women, especially, do we feel unheard? And it does not matter if you've accomplished a whole lot, because guess what? A whole lot of us have accomplished a whole lot of things. But at the end of the day, your mind still goes to that thought that for some reason you are not worthy. For some reason, you haven't done enough. And I'm here to tell you that we're going to cancel that, and we're going to begin to walk in our greatness that we were called unto, because we are a beautiful people, period, end of story. And so that resilience that we have built up because of what we have been through is what is going to take us to the next level. So what I want to make sure I say to you is this. The truth is that we know that racism exists, but how we psychologically interpret what it says about who we are, because this is the thing. This is about identity. Perceived racism will wreck identity and potential. Remember, I said we have options, and when you think you don't have any, that's a problem. So if we don't get this corrected, then what happens is we continue to demolish our own identity, and we don't believe that we're the beautiful people that God created us to be. We don't believe that we can do great exploits. That's what happens. And again, you're not going to do them all by yourself. You're going to do them in a collective. Like right now, we're collectively here together supporting one another. So what happens is, it's the difference. This is what I want you to remember. It's the difference in the truth that racism exists and our perception of who I am not versus who I am. Second part, it is the difference between what you can't do and what you can do. So that's why we have to rectify this. That's why there must be a solution. And that's why the solution is every last one of us.
Raquel, you told us to choke. Yes. I absolutely agree. And we need even more people at the table, and not just Black people. We need people who actually, I don't want to say, I hate the term a seat at the table. I absolutely hate that term. Because whoever said I wanted to eat at that table? But the people who are actually making the policies and who are running the government and these different organizations also need to be a critical part of this conversation, because in order to really do everything that we've talked about, we have to address the laws and how this stuff plays out. Yes, we have to encourage and inspire each other. We have to continue to build the bridge, build the foundation. But in order to build the house, we need everybody to collaborate and talk together. We need to see each other as human beings, as individuals. So when we start, you guys were talking, it was so much good, so many good nuggets. I can't even go back and remember everything everybody said. But when we're going back and talking about the implicit bias and the counter stereotyping imaging, imagining the individual as the opposite of the stereotype that you've developed in your head. If you look at them as an individual, seeing the person as an individual rather than a stereotype, all of these things that we've talked about, we need to collectively and collaboratively plan how we are going to address this. And there's a huge thing that we haven't mentioned that I really want to make sure we talk about. The fact that in order to exhibit racism implies a certain level of authority. So you have to have a certain level of authority to exercise racism on anybody, because you are essentially the lawmaker and the punisher if you are the authority. So in order for those ramifications to happen, it's from the top down and not from the bottom up.
Correct.
And so we have to understand the history of racialization in this country. I mean, it goes back to the 1600s, for crying out loud, back to things like Bacon's Rebellion and the annexation of Texas and all this other stuff, where you saw how the central role of the government was shaped by economic and social practices. This stuff is so deeply ingrained in this country that's why I say it's going to take a lot of conversation for us to really get down. I mean, and then you fast forward to the 1900s, where you had the New Deal and the GI Bill and what that did to labor laws and the Jim Crow segregation and the lead to modern day gentrification. Like I say, I'm all for eat, play, work in great neighborhoods, but why on earth can we eat, play, work together? Why are you putting people who've been in these communities for decades and making it so that these families can't afford the home that they grew up in? That is unjust. That is not okay. And so we have to really get to the root of race and the role of government. I mean, it's deep, and really addressing all of the different components of racialization. So you have things like interpersonal racialization or internalized. You guys talked a little bit about the internalized, but you also have the institutional and the structural elements of racism that we cannot address from the ground up. Again, it has to come from the top down. And the only way to do that is to engage everybody in conversation. So I know some people are just, I mean, don't get me wrong. I love my Black people. I am Black all day. However, if we are talking about loving and, appreciating one group of people, we have to appreciate everybody. And we need everybody to come to this table in order for Black LGBTQ, you got the Latina population. Everybody needs to have an active voice to address their specific concerns within their communities, because there are similarities that reverberate across the board. It's just a matter of coming together and figuring out, okay, you know what, this policy right here, the 13th Amendment, it got to go. It needs to be rewritten because we're tired of seeing our Black men shipped off to prison. Like, we're tired of you justifying this and saying, oh yeah, but we freed you. No, the heck you did not. Because you can see it in things like environmental racism. Why are most of the landfills and the horrible environmental eyesores that we see throughout society always located on the south side of town, or the side of town where the minorities live? That stuff is not accidental. It is not accidental why so many Black and brown communities live in some of the most urban, crowded, packed-in areas. That's not accidental. We have to address this from jump. We got to go back 300 years. And I don't mean to make it sound impossible, but we have to understand that history and just how deep this is, so we don't play ourselves. Because you got to come up with a game plan and not go in there blind. Because, I mean, so many people have said and pointed out the fact, like, hey, these are the numbers. These are the statistics. So if we know this stuff and we go in there with our facts correct, nobody can do anything but say, you know what, maybe we should listen for once and actually do something about this, because ultimately it's only hurting us. And truthfully, it is. Look at our GDP and what's happening in this country from a financial perspective. All this stuff is related. So anyway, I'm going to get off.
Yes, it's all related. I mean, and I'll jump in and say too, I think it's interesting what's happening now, kind of this awakening from our peach brothers and sisters. There seems to be this awakening now in terms of the true impact of race. And so something is shifting, something is happening. And I think one of the things I encourage all of us, you know, as people of, well, first speaking to people who may be listening to this who are not of color, please be willing to ask those questions, like get honest, you know, start having these conversations, even if it's not someone that you know who was someone of color that you can pull aside or whatnot, but start talking among this, like with your family and friends, like ask them about news stories. Like, have you heard about Breonna Taylor? Have you heard about how no one has been arrested yet? Like, have you heard about Rayshard Brooks, who was just killed? You know, so kind of start to engage people, because oftentimes we have these sessions, these webinars, these conferences, and it's like, we need to, do this and make a change. You know, the thing that makes change, talking about it. Like, open your mouth and talk about it. Like, have that conversation, ask the questions with each other. And I think as people of color, like, as our energies permit, right? Also being willing to have the conversations with those who ask. You don't have to. I've shut down a lot of people who have come back and be like, well, can we? No, I'm grieving right now. I can't do that. So just being willing to also have those conversations as well. And kind of hitting back to, even with some of the issues among us as people of color, like, let's start with being kind and generous to ourselves too. Like one of the things that I've also, kind of seen in some of the communities I'm in is just even some of the conflict between Africans and then African Americans, or like Caribbeans and then Africans, and then just kind of that whole cycle, right? So it's like, let's really get honest about what bias looks like and what discrimination looks like, because we all have it. It all shows up. And this work is intentional, active, and uncomfortable. Right. So please prepare for that and buckle up and just know that we're in for a ride. I also want to encourage our non-people of color who may be listening. This is a time where everyone is talking about it, and so it may feel easier to do it. But when people stop talking about this, the work doesn't end, right? Like your work still continues. Please remain engaged. Also want to challenge you to check yourself if you're finding that you are looking for this sense of validation because you are quote unquote woke. You know, check that. Like why do you need that? Like, why does someone have to say that to you? So be willing to do the work and be willing to do the work for the right reasons because we need each other. It's so important.
Yes.
Right.
Thank you, Leslie. And we're
so much. I wish I could chime in. I know time is of the essence. I see some of the questions or the comments that people are making. And I don't know if we want to address them now or.
Well, I was going to wait for some of them. There are a couple that we are going to address in our part 2. I know some of you, I am so excited that you guys are so excited. And there's so much to talk about. And I apologize that we couldn't get to all of the questions. But we do have a moderator who has taken note of each of your questions that we will address them in part 2 when we talk about the solutions of what we've presented tonight. There is one particular comment where Jare asked, is there or can we create a network or website of Black doctors, therapists, where folks can have a one-stop shop? I believe that we would be so much more open and honest with Black doctors, but most of us rely on word of mouth. It would be awesome if we could go somewhere and find dozens of them to choose from. And Jare, just wrapping up, we're going to tell you a little bit more about each of our services as we stop. Heal the Public, which is my business, is actually that. It's a brand new business, but it is like a green book for Black doctors and therapists so that people around the country know exactly where to go. And there's actually a podcast that Shingeri is a part of as well that we are launching next month called Crucial Conversations, where we will have these types of conversations on a weekly basis, where we talk about anything from incarceration to voting, to Black hair, to the role of Black women in society, the mammy, the Jezebel, the Sapphire, like just really delving deep into these different elements and how it has played on our health outcomes over time as a people. I also want to give Raquel and Dr. Ojima and Shingeri and everybody a chance now to tell you a little bit, and then we'll wrap up. So, Raquel, do you want to go first?
Yes, ma'am. And because we're going to be friends and you're going to put me in that book of yours, it's Raquel with the
Raquel, I'm sorry.
Yeah, it's okay. It's okay. This has been a great night. I thank Shingeri and Giselle and just everybody for being here. And thanks to all of you who tuned in. I've thoroughly enjoyed myself and I feel supercharged to just go on and especially to be here for the second part, if you'll have me. Now, the way you contact me, and I found that we can't really put anything in the chat. So I'm just going to say it. It's on the screen. EmpowerYou.com is my website. You can get everything that is Raquel there, but to drive it home, I'm a therapist, a mental health therapist and an addictions therapist, and I'm a John Maxwell certified trainer, speaker, and coach. And so they call me the clarity coach. So if you need some clarity in your situation, you might want to call me. And the podcast is Everything Mindset. So it's a masterclass in mastery of self. It's where you're going to get your life. So join me there. It's empoweryou.podbean.com, but you can also get it on my website. And I have a free event coming up where I want to help parents learn what their children's strengths are under pressure. We talked about stress tonight, right? So with this COVID and with with everything going on, Black Lives Matter, we're stressed out. Your children may be under pressure. They're not sure when they're going back to school. They're not sure if they want to go back to school or they want to stay in the house, and you keep trying to help them with their math homework with no success. I want to help you learn to look at your children's resilient nature in just a beautiful, positive way. So this is a free event that's going to be next Thursday. If you email me, just when you go to empoweryou.com, just send me a message and I'll send you the link, or you can look for me, Raquel Reed, online on Eventbrite, and you'll find it there. And the last thing I want to share is that I just released 2 books on the same day, June 29th, one for CEO women and one for their CEO kids. And that second, when both books address chaos, the chaos that we've been going through, and they are going to uplift and encourage you and build your faith and resilience. So make sure you get that too. And you can get everything I just talked about on empoweryou.com minus Eventbrite. So if you want the information for the free event that's happening this Thursday at 7 o'clock, coming up next Thursday, then just send me a message on empoweryou.com and I'll make sure you get that information.
Awesome. Girl, you are doing it. Okay. I guess I should probably say something about my books too. I'm releasing 2 books this summer as well. One of them is a cookbook, but it's called Ketoish, and it's an exploration of high protein plant-based soul food. And then the other one is called Intermittent Keto, and it's a hybrid intermittent fasting program using high protein principles. And I'll ask Shinieri to put my website into the chat box if any of you want to contact me. Dr. Joma, do you want to share a little bit about what you're doing?
Well, I'm doing a lot, but I'm kind of on a hiatus given my current condition. But I want to first off thank my sister, Shinieri, for putting this together. I think it was absolutely needed, and you knew who would contribute very well to this topic, and I think everyone was excellent. I want to thank my family and friends for watching, and I hope that you were enlightened by all the information that you received. You'll hear more from me in the part 2 or the more other sessions that we do if I don't have this baby early. But I think it's absolutely amazing. I'm glad that they're recording some of the things. I know there was some medication related questions that we'll get to in the next part. But I want to thank you all. And then kind of touching back on what Dr. Giselle said real quick about, and also for Dr. Leslie, she mentioned it too, about a lot of the non-African American people who are viewing this. Just like she said, it's not something that we want to say thank you for per se, because it should be something that should become natural. And it doesn't come natural for everyone. But I think that it's a move in the right direction to understand why this was needed, why we needed to talk about racial disparities in this country, and why this is, I hate to say hot topic, because this is our life. This is what we go through every single day. So if you want to say hot topic, just say we're on fire all the time. But I think it's amazing that this was put together, and I know there's several more type of webcasts that are going on with the same topics. But I wanted to tell you all to stay on board. Just like Dr. Leslie said, stay on board. You know, some things, social media makes things, fluctuate and go down, but this is our life. Our life does not go up and down. We are African American women, and that's what we will always be. So this is our life, and ask questions, just like what was said. Ask questions. It's okay to ask questions, and us as African Americans need to answer them, address them. Don't be tired. Don't be tired. We're doing this for future generations. I know sometimes we get frustrated having to, just like Raquel said, prove ourselves all the time. It does get frustrating, but it's our life, and we're doing this for the future generations to come. So definitely, I will see you all in part 2. Thank you all, and especially to my friends and some of my colleagues. I saw some of my colleagues from work sign on. Thank you for watching, and stay tuned.
Awesome. I'll jump in. Thank you all so much for this. This has been an amazing conversation, and I hope you all come back for the next part of it. But part of what I'm doing, as Shinira mentioned earlier, I'm a physician. I'm more so operating right now as an executive coach as well as a speaker. My life's work is really to help people manage difficult situations in their life. I want people to learn how to live better and love better. And that honestly really starts with how we manage our emotions. I speak on colleges at universities around this issue, helping young people to reconcile these issues. Also doing corporate work as well. I'm doing learning and development. But I want to I guess point you all to my site, Shop Heartwork Now. I have developed a deck of conversation cards that are great for just helping you to go deeper in your conversations with those who you love, especially now when we're all indoors with Corona and quarantine. I encourage you to get a deck of those cards, pull them out, have these deeper conversations with your kids, with your spouse, with your boo, your bae, whoever. These are conversations that are these are questions that are meant to help you get to know each other beyond the surface and really kind of pull back some of the issues that you may not have discussed. So that's Shop Heartwork Now. Let me know if you get some. You can also follow me on social media at HeartWorkDoc, HEART Work Doc. Again, I'm there posting as well. Kind of have also been on a hiatus because, with the kids, being inside and all that. But you can definitely still reach out to me via those two platforms. And thank you all for having me.
Wonderful. Delanya?
Hi, everybody. So thank you guys so much. I refuse to be kicked off due to technical issues. So I am back on. So I appreciate you. And I did not miss a beat of this conversation as it is much needed. And I appreciate being a part of it as well. So staying connected to me until the next time we all come together to continue to share information on this much needed topic. I am a nurse and staunch advocate for patient advocacy as well as healthcare advocacy. I do consultancy work. I'm a health coach, or really a wellness coach for the most part. I have my own television show, which just launched 3 weeks ago. And you can follow me on Women's Wellness Lounge or the Women's Wellness Lounge.tv or DelenaWatkins.com. So I do have a lot of projects that are going on. Any of you that would like to utilize that platform to share your perspectives and information about the works that you're doing, feel free to send me an email at info@DelenaWatkins.com. Again, advocacy is where I live. Preventive health information is also where I thrive. So this has just really elevated my area of information and concern to share that as well. So Shinyeri, you know how much I adore being part of anything that you put on, anything that you feel is important. So thank you for inviting me. And it has been a pleasure meeting all of the other panelists as well. So I look forward to part 2 and being able to share in that space as well.
Awesome. Awesome. Thank you, ladies. This was amazing. I feel like I brought in the dream team for healthcare advocacy amongst, African Americans. This is a wonderful conversation. We went a half hour over time, but this conversation was fire. It was something that really hit a lot of points. And of course, we're going to have a part 2 on this. And that's going to be our opportunity to talk about solutions and initiatives that we can take. Now that we've identified the problems, which are many, now let's come up with a plan, a solution, and let's get some initiatives going. We came up with a couple of great ideas already. So I'm hoping to our audience, you will come back. We'll be announcing the next part 2 of Race and Health, which will be in August. Once we solidify a date and time, we will be sure to let you know. Please, follow my website at the Eze Way. That's www.thezeway.com, theezeway.com. You'll find updates. Also following us on social media at EFH Center. So again, thank you, ladies. Thanks to Giselle, Dr. Leslie, Delena, Dr. Ijama, and Raquel. This was awesome. I look forward to having this platform again with you ladies in the next couple of weeks. To our audience, thank you so much for joining us. This has been a great conversation, and we're going to see you next time.
Bye.
Bye-bye.
Bye.